Thank you very much indeed, Alongo. For another perspective, we'd like to hear from Olive Sentumbwe-Mugisa. Olive represents WHO, and I understand she's going to be talking about WHO's guidelines in this area. Olive, thank you.
Good morning, ladies and gentlemen. We are delighted to have this opportunity to talk about this subject today. And I think for us in Uganda, I must say that the work which we are going to present is a mixture, because we had to respond in 2005, 2006, we had to respond to a humanitarian crisis in the northern part of the country. And that is how this became obviously a very big problem. And we realized that it was actually not only the north, the entire country, every village in Uganda has this problem. And so we had to make sure that the health sector has some guidelines at least to see how this can be done, at least beginning with the health units that were already working on the various survivors and their issues. So I've skipped the slides on the definitions because those were done. Even I think the global statistics must have been given yesterday in the morning, just to highlight that this is a very big problem for all of us in the entire world. But would like to emphasize the Uganda data, where almost, if you count 10 women, 6 of them will have suffered some form of physical violence, either sexual or physical violence, in their lifetime. So yesterday, a question was asked: how come we are not the workshop is not having survivors? For us, we thought that, we are here. Because if every 10 women in Uganda, 6 of them, it's a difficult subject, but it is a common subject. And in regard to women who have experienced intimate partner violence, the Uganda Demographic Health Survey of 2006 showed that at least 3 in every 10 have had this problem. So we believe it's as common as that, and in every level of society. Our data, which has been collected again, 2006 and 2010, 2011, shows us the regional differences that exist. And the last one, the 2010-2011 showed us that if you look at the percent of ever married women aged 15 to 49 who have experienced physical and or sexual violence, currently the eastern region is leading the country, with the Atesot mostly affected. When this data was analyzed by religion, the Pentecostals led the issues, and in regard to rural-urban setting, the rural people are seemingly suffering more than the urban people. When we looked at the trends between 2006 and 2010-2011, we see that overall there is a decline. However, the Kampala, which is urban, is seemingly showing an increase instead of a decrease compared to the other regions, as well as the north. Remember, our response started in the north. We've looked at the risk factors in the country, and they include exposure to child maltreatment and abuse, harmful use of alcohol, and of course other substances. We have so many substances here of addiction that are being used, and they've been reported as a very big problem in many districts where we've been. And of course, gender norms and values of acceptance of violence have been mentioned as a very big factor. This slide shows further analysis of the Rakai data. I must thank the Rakai community at this juncture. They've shared their data with WHO, our RHR section at the headquarters, and further analysis shows that women aged 15 to 49 who had ever experienced intimate partner violence were 1.6 times more likely to subsequently acquire HIV than those who had never experienced intimate partner violence. And we'll continue to partner with the Rakai community to make sure that we take this further beyond that, to continue to work with the community. We have selected some few reproductive health consequences which we want to highlight here based on Ugandan data. And in a study in Wakiso district, women who experienced intimate partner violence were about 3.78 times more likely to have low birth weight deliveries than those who had not suffered GBV. And Kasho showed that 16% of women report experiencing physical violence during pregnancy. So pregnancy seems to be a factor in violence, and yet it should be a very quiet time. Another study by Kaye in 2006 showed that women who had experienced intimate partner violence during pregnancy were 1.4 times more likely to develop obstetric complications such as hypertension, premature rupture of membranes, and anemia. And another, Karamaji, working in Mbale, showed that infants of mothers who had ever experienced intimate partner violence are 2 times more likely to experience illness or diarrhea. So this is a huge problem for both women and their children, and I suppose their families. We now show the social and economic consequences. Our data, which exists in Uganda, shows that children within violent affected households may experience mental and behavioral disorders, including depression, anxiety, and may actually have poor performance at schools. And there are direct and indirect costs which are linked to this problem, which has been done in 2011, to show that the annual economic burden of domestic violence for Uganda is about 77.5 billion Uganda shillings, which is about 0.35% of the Ugandan GDP for 2011. And yet, the cost of annual public provision of services, taking into consideration health, police, and judiciary, was estimated at 56 billion, which is about 0.75% of Uganda's national budget in 2010-2011. So for us, this is a social, economic, health problem, name it, which has to be dealt with. So last year, in October, we carried out a readiness assessment mechanism for the prevention and response of GBV, wondering how ready was Uganda to address this problem of GBV. And the dimensions that were assessed included key informants' attitudes, key informants' knowledge, scientific data, current programming, legislation, mandates and policies, and the willingness for people to address GBV as a problem. We looked at the institutional links, we looked at material resources, human and technical resources, and informal and social resources that the country has to address this problem. We had 34 key respondents, and overall, the readiness which Uganda has to address GBV was rated at about 61%. When you look at our radar diagram, it shows that legislation and mandates were definitely, we have so many policies, as you can see. So the policy environment is ripe now to address this problem. However, the lowest resource that we have is the human and technical to be able to address the problem in all the sectors. This is our radar diagram, and it shows those different dimensions and their scores. And we'll share this with you. So Uganda, now I'm dealing with the health sector, but the health sector has worked with so many other colleagues, and all of, I think, the Ugandan participants who are here, in one way or another, we have worked with them. Because developing the guidelines to address the health sector needed the involvement of these so many stakeholders. Our guidelines initially were based on the WHO old clinical management of survivors of rape, if you remember such a book. So we adapted that one for our situation, and of course added chapters which were suiting us at that time, things like networking, M&E, counseling and communication, the background to gender, because we knew that our health workers, as they entered service, these were areas they had not dealt with. Later on, and that is this year, we've embarked on a process where we are reviewing our guidelines again, because new information has come in, as you've heard since yesterday. New concepts have come in, especially strengthening the issue and area of IPV. And WHO has new guidance, and I believe you could have come across them. There is the first one which came out, Preventing Intimate Partner and Sexual Violence Against Women, and it gives you the 4 areas of work and the 6 steps which you have to go through when programming. And more recently, Responding to Intimate Partner Violence and Sexual Violence Against Women. And in June, we had to add a summary, which is not yet input into this, based on the ongoing evaluation work, recommendations based on evidence. So it's work which is in progress. It seems you never finish developing these guidelines and say, here I am. You just have to make sure that you're listening into the researchers who are here and taking on their work. So using the data we have, we've developed advocacy packs, and we are ready to launch them. My colleagues, it's 2nd September, we'll have a big GBV advocacy pack launch for Uganda. And of course, we are working with so many NGOs and government sectors to address the health issues. For us, this was important because health as health is a very big contributor to what we think. First of all, it's the woman who has suffered this, or the child, or whatever, but this time let's take the woman or the girl child. The health sector, as Professor told us yesterday, and so many presenters, has her own needs, which must be answered. But later on, most of the other sectors will use the health information, the health data that you've generated to continue with investigations and reach justice. So if the health workers are not properly empowered and trained to do their work, then it becomes a huge gap. And this is what drives on, to make sure that this is done. We still have a long way to go, but we think that this is the work we have to do and make sure that the countries in the region are responding and doing their work according to the set standards and the research recommendations that are coming in. We held a workshop as WHO and the other UN sisters in June here for 7 countries. All the countries which are here were there, plus Burundi, Rwanda, Eritrea, and Ethiopia. And this is when we shared these guidelines. And at the end of the workshop, 5-day, we worked out the issues in the region, and they were in relation to these findings. When you look at the legal frameworks in the region, we have legal frameworks to promote gender equality and prohibit at least some forms of violence against women. Most countries have this. When you look at policies, they are mentioned. If you look at health, our health policies in reproductive health, in HIV, somehow mention GBV. But the programming and the service provision after that is not real, and we need to strengthen that part. A commonality across most countries was that when While laws and policies exist for all of us, implementation was a what? A weak area. Especially integrating this in the very obvious areas of HIV service delivery and reproductive health. We looked at the data. Data exists. Most countries have this, and they have actually incorporated it in the demographic health surveys. When you look at protocols, many countries represented at the June workshop have a process in place. They are either developing, some are reviewing, and they're working with these different sectors to make sure that these protocols are in place. Some of them are updating. When we looked at political commitment and budgets, it was identified that having a national budgetary line item for gender and violence against women is a very important area of work, but this was the weakest in the region. Only Rwanda had a real budget line. All of us are trying to work around engendering budget, different sector budgets. In most countries, there is no real government sector budgets. And if this is not happening, then we can't do the work we are all talking about. Coordination of some sort is going on. Referrals were very well mentioned by, is it Datia from Tanzania? The issues in there. Training of health workers is somehow going on in service, but our training institutions are silent. And this is an issue, because we will not afford the what? The backlog. We do not have the resources to train people in service. So the training institutions must now take on this, because it's a real public health problem. Coverage of services definitely is still low, because it's expensive to train in service providers. Different models of care exist, as you have heard from the different people, but the integration in the real possible sustainable areas has not taken place, and it's weak overall. And this is why we must focus. Just one or two countries, I think, at least Tanzania has mentioned that it is doing IPV, trying to do IPV in the ANC. I think Uganda is trying to do something, mainstreaming it in HMIS, in the trainings. Yes, something is going on, but it needs to be strengthened. Prevention issues, evidence is there that we need to have these strategies, but the existing ones are mainly in the community issues, and they're mainly by NGOs. And definitely, government sectors need now to be strengthened on this. And probably lastly, monitoring and evaluation. We have the real systems. We can do DHSs, but what are our different sectors doing to capture this issue? So we propose that those areas which have been mentioned should be considered in the afternoon session as a take forward in regard to research, policy making, and programming. Let's address the real issues that countries have raised so that we can, mainstream with their real issues in regard to research. Sometimes research does not answer country problems, and we need to focus on what countries have said. Those are our references, and I'd like to thank you very much for having given us this opportunity, UNAS and IOM, to make this presentation. Thank you.
Thank you very much.